I want to remind everybody that we are hosting this session on the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, and the Tsleil-Waututh peoples, and the Métis chartered community of the lower mainland region. Importantly, you are all coming from different places across this province and even outside other places in Turtle Island. And we need to continue to remember to respect and honor the land and the people on it, and elders past, present, and emerging. Next slide. So province-wide rounds, as you all know, is a collaboration between University of British Columbia Division of Nephrology and BC Renal. But importantly, none of it and the support of the educational programs in both the BC Renal as well as the UBC Division of Nephrology would not be possible without the support of our multiple sponsors. And they're listed here in alphabetical order with their logos, and also include, of course, our regional health authority partners. Next slide. So this is an exciting talk. I think this year is going to be full of myth busting and things that we thought we knew and didn't know. So today it gives me great pleasure to introduce Dani Renouf, who's a registered dietitian and chair of the Provincial Dietitians Committee. She's been in practice for over 15 years and is currently doing a master's in quality improvement and has taken a year away from clinical work, which is quite distressing to her patients and her colleagues. Nonetheless, she's doing great work, as well as Dr. Mohammad Atiquzzaman, who is a research scientist at BC Renal, BC Kidney Research Unit, and UBC Division of Nephrology, doing pharmacoepidemiology and work to help complement some of our questions and answers. And so the bulk of this will be presented by Dani Renouf on myths and truths on nutrition management of potassium and chronic kidney disease. So without further ado, I'm going to turn it over to Dani. Thanks so much for all of you for being here, and Dani and Atiq for your presentations.
Thank you so much for the introduction, Adira. It's such a pleasure to be here doing rounds. I always look forward to this, and looking forward to presenting with Atiq and showing you some exciting stuff. Great. So I have no disclosures, and I live, work, and play on the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh Nation. I would like to extend some thank yous to the the PHC and BC Renal dietitian teams, Dr. Michelle Wong, BC Renal, and Atiq. So I will talk about potassium physiology with and without kidney disease. I will go through some research underlying the reasons for hyperkalemia. I will speak about what's called bioavailability, or how available potassium is during processing in foods. And really, I center all my talks around patient messaging and how do we provide information to our patients for better outcomes. And I know this is a contentious topic, so I will be very respectful of the fact that this is a lot of new information, and it's really the beginning of our conversations around potassium management. And my talk is only one talk of many to come around this topic and exciting research and innovation that we will be doing in nutrition over the years to come. So as you know, potassium has been evolving as a concept, and what we used to know and what we used to do and share with our patients is really that there's a potassium restriction in milligrams. And because of that, many nutritious foods like plant-based proteins, fruits, and vegetables were eliminated from the renal diet, what was called the renal diet at the time. And primarily white grains, animal-based protein, and a diet low in fruits and vegetables was prescribed. And there was very little or no focus on processed foods and food additives, mainly because these are rather novel additions to our food chain. And, 30, 40 years ago, 50 years ago, that may not have been the case. So it's really important to consider nutrition as a science, as a temporal phenomenon. And just to hold your beliefs lightly when it comes to nutrition, and really use a multidisciplinary approach. So as you can see, we had these potassium lists with milligrams of potassium on them, and we would encourage patients to use the lower potassium choices. Over the decades, of course, we now know that processed food is a high source of potassium additives, and the processing, which I'll go through, of foods itself can raise potassium. So by processing, I mean just taking, for example, tomatoes and turning them into tomato sauce. Therefore, as we learn more and more about the fact that it's not really milligram for milligram, absorption differs between foods, we now are looking back at promoting plant-based eating and to promote fruits and vegetables, which of course puts our patient experience into a bit of a tizzy, and a lot of patients are confused again. I thought I wasn't allowed to eat Brussels sprouts, and now you're telling me I can. So we have quite a bit of work to do in order to sort of build trust and ensure to patients that they're going to stay safe, because these are some of the things I hear when I talk about nutrition to patients. So people feel they're getting mixed messages. They were told never to eat certain foods. There's nothing left to eat. Everyone's giving me dietary advice and I'm overwhelmed and scared. I don't want my kidneys to fail. So now going back to 2020, when the Kudoki and KDIGO guidelines came out, it's evident that there is still quite a bit of confusion around the potassium issue. I hope that after today's talk, we can open the conversation and really look at the science behind why we're saying the things around potassium that we are. At this point, there was a comment around the scarcity of studies on how diet can influence serum potassium levels in CKD. And there was an acknowledgement that there is a lack of evidence, and most of the guidelines around potassium, low potassium eating, are opinion-based. There was a mention that the association between dietary and serum potassium is in fact a weak one. And in the diabetes guidelines, there's also a mention around, making sure we keep counseling individualized, really looking at those salt substitutes and food additives that contain potassium. And then the same guidelines state that potassium will be restricted in advanced CKD. It's recommended that people do avoid high potassium, whole foods like fruits, vegetables, and nuts. And other guidelines, including some of our local guidelines, still have potassium lists with milligrams of potassium listed on it. And so that's still something that's being provided to patients. And I will talk about why we need to start looking at different ways of educating our patients. So let's take a pause here and let's look at normal potassium homeostasis. So our bodies are incredible machines, as we know, and they do a really, really good job of managing potassium. In fact, most of the potassium in our body is found in the intracellular space. So it's in our cells. That's accounting for about 98% of potassium. And so it's used, for muscle function, cardiac function, various functions in the body. What stimulates the entry of potassium into the cells is partly insulin. So if you have a good insulin, mechanism going, that will stimulate both glucose and potassium to enter the cells. The other 2% is excreted through the kidney, and the kidney does a really good job of removing potassium from the body under healthy conditions. Of course, some of the potassium is also eliminated through the bowel, but the kidney is primarily responsible for removing the potassium, the excess potassium from the body. And there's a lot of crosstalk that goes on between the intestinal lumen and the extracellular space. Another aspect to consider is that if you are taking samples, serum versus plasma potassium can have a difference of about 0.36 as found in this study, where the serum potassium is higher than plasma potassium. So when serum measures are collected, they are clotted before analysis. That clotting further releases potassium, and the sample will start to read higher and higher potassium concentrations as the blood clots. So we know this is really problematic if there was an issue with drawing the blood or collecting the samples where we see false high readings of potassium in the lab tests. And then here we are treating this hyperkalemia that in fact was just brought about by prolonged, resting time of the sample and this clotting mechanism. So this is another really important consideration when we're looking at potassium. The third component, along with potassium homeostasis and the serum sample versus plasma sample, is that there is a circadian rhythm to potassium. So depending on what time of the day, my blood is drawn, there will be differences in my potassium level. That is related to eating. So of course, after someone has eaten something or I've eaten something, my potassium levels will go up. But there are also certain times of the day where the potassium is higher in concentration, specifically between 1 and 3 p.m. in the day. And that is in people with and without kidney disease. The lowest mean serum potassium concentration is usually in the evenings around 9 p.m. And in a person who has impaired kidney function, in fact, the fluctuation range in potassium between the highs and the lows is much greater. So there's a really big range that can be really up to 1 millimole per liter different as the day goes on. Again, in somebody who's living with kidney disease, there's a shift in how homeostasis works. Of course, there's impaired aldosterone, which means that there's issues with potassium excretion. The kidneys can't excrete potassium as well. So what happens is the colon adapts to excrete most of the potassium. This becomes really important when I go into the food component of potassium management. But what's really important here is that gastrointestinal potassium secretion can increase as kidney disease advances up to 80% to remove potassium from the body. Of course, this will be a slower process than through the kidneys. However, it's really important to note that the body does adjust to remove potassium that is eaten through the bowel instead of the kidney. And the other pieces to consider when we're talking about potassium in people with kidney disease is really the impact of medications that are so important. They're so necessary for controlling blood pressure, to make sure that we are protecting the kidneys long term. However, a side effect of those diuretics and ACEs and ARBs is higher potassium in the body. So as I mentioned, hypoaldosteronemia is an issue and means hyperkalemia in the case of people living with kidney disease. Of course, there's the risk of acute kidney injury, insulin deficiency, especially with people who have diabetes, and just a lower filtration rate, which means the kidneys are slow to remove the potassium that they were once able to remove. And the medications like beta blockers, NSAIDs, ACEs and ARBs, the diuretics, heparin, and some of the immune therapies are also, immunosuppressive drugs rather, are also going to raise potassium. So you see how much the disease states and the medications are really contributing to hyperkalemia, and that food is just a small component of the contribution, and that the food that does contribute is really the very processed foods that I'll go into discussing shortly. I did want to just zone in on diabetes and hyperkalemia because, in fact, almost 70% of the people we see in our clinics have diabetes or living with diabetes as well. And so as inflammation occurs over time, people have insulin resistance, plus other factors also contribute to insulin resistance in people living with diabetes and kidney disease. This insulin resistance means that there's no longer that stimulus for potassium and glucose to enter the cells. So where that now means the potassium and the glucose are sitting are really in the bloodstream. So quite often with people that I see in clinic presenting with hyperkalemia, it's really a diabetes management issue. And we work a lot on trying to manage the diabetes more than anything, which is again, a big shift for people. They're used to just having their potassium managed, with a prescription of what not to eat. And it's so much bigger than that. It's really a big picture approach, and it requires, a team approach to manage. So back to the 2,000 to 3,000 milligram prescription, this was something that we used to really push and really sort of promote and be prescriptive around. This meant that a lot of plant-based foods were excluded, like nuts, seeds, beans, fruits, vegetables. And this approach may have seemed logical. If something has a high milligram of potassium, let's restrict it. But we now understand there are so many factors that modify absorption, and actually sort of, we're more of a black box, I guess, as human beings, that just because we eat a certain milligram of potassium, it doesn't necessarily mean that that's going to translate into a rise in our serum potassium levels. So this is the Balance Wise study by Dr. St. Jules and other authors. And it just shows you, all those dots are basically showing you that there is so much variation between how much potassium was consumed in these participants and how that potassium actually translated to serum potassium. So you see that there's a very, very weak correlation between how much potassium was taken in and how much showed up in the serum. And that only 2% of the variation was diet related. There are so many factors that influence serum potassium, and we have been putting the lens on diet for so long as the main factor. So in fact, this is where our thinking is now shifting, that there are so many other factors to consider related to someone's health when we're looking at serum potassium. There is very low quality evidence that restricting potassium intake, especially from whole foods like the plant-based proteins, the nuts, the seeds, the fruits, the vegetables. And these studies really show that when dietary patterns were looked at in, for example, vegetarian type diet, a plant-based diet, you see that there was very few studies, one in fact only, that showed increasing potassium intake over 5 years led to hyperkalemia. All the other studies really didn't show that eating more potassium from healthy foods in fact led to hyperkalemia. So I guess we're at a position where we can potentially say we have gone under some faulty reasoning here, that when we labeled foods as low, medium, and high potassium foods, we really glossed over the fact that there is no evidence for this. So we had this hypothesis. We were working on this hypothesis that potassium restriction is useful based on this assumption. We also know that meat increases net acid production and can lead to more acidic milieu. In the gut, there are more proteolytic bacteria that flourish and can cause a higher degree of uremic toxin production. So using meat, based diets is something that we know can potentially worsen kidney function, and that plant foods are in fact less of an acid load, and that they are higher in fiber. They help control diabetes management as well. We know that things like juices and again, anything processed, juicing is a processing, tomato sauces, soups, these are all concentrated in potassium. And we know that if we boil something, remove that water, because potassium is water soluble, we're actually, removing some of the potassium. But in the case where we don't do that, it can concentrate the potassium, so in dried fruit. So you can see how it's really complicated, and you have to sort of go food by food, really exploring things on an individual level with your patients. And this isn't something that can be done in 5 minutes or one session. This is a relationship. So I'll go into bioavailability of plant versus non-plant foods. The studies have shown that the bioavailability, or how available potassium is in fresh fruits and vegetables, is up to 60%. So in some cases, it can be less than that, because the fruits and vegetables are bound to fibers. And these fibers prevent the potassium from being bioavailable or absorbed into the bloodstream. Next group would be the unprocessed meat products and animal-based products, which can have up to 96% absorption of potassium. Now, I'm not saying never eat meat. That's not the message here. It's just to be aware that if you're talking to someone who does exceed, their protein intake overall, that might be a reason why the potassium is high. So I'd rather focus on that than to say, don't eat these fruits and vegetables, if that makes sense. Finally, you can have up to 100% absorption from deli meats that have potassium additives in them, and processed meats in general. So in this study, where it was a very small study of 11 healthy volunteers, they compared the low bioaccessible or bioavailable diet to a high bioaccessible diet. And they found that there was actually a difference in serum potassium levels based on those people who ate the low bioavailable diet, which means they had more fiber in their diet. So they had better potassium control. And that was determined through urinary excretion of potassium. Like I mentioned already, high protein diets are linked to hyperkalemia. So high protein diets aren't great anyway for people who have chronic kidney disease and aren't on dialysis. So when we're trying to prevent progression of kidney disease, we do have to really moderate the protein intake anyway. But if the proteins are coming mainly from animal sources and not from plant-based proteins, you may see a rise in serum potassium. And so it's really important to kind of go through the diet and make sure some of the protein sources are also plant-based, because again, the plant-based proteins have a lower acid load and a higher fiber content. Another important consideration is that, when you have a higher fiber intake, you are reducing the risk of constipation. And we know constipation has consequences above and beyond just digestive health. And so if you have a higher fiber diet, you are removing more of the potassium through the bowel. And as kidney disease progresses, it's really, really important to prevent constipation, to ensure that potassium clearance is going as best as it possibly can. So I guess now comes up the question, do dietary potassium intakes actually lead to mortality? And the answer from this study is no, from a series of studies is no. In fact, higher potassium intakes coming from fruits, vegetables, plant-based proteins are beneficial. There are many benefits, as I mentioned, on the acid-base balance. I haven't mentioned the benefit on cardiac health, good benefits on diabetes outcomes. So really, by promoting a diet that's plant-based and higher in vegetables, fruit, and plant-based proteins, you're preventing people from having complications that may lead to mortality. So this is really important. And in fact, lower potassium intakes, restriction of potassium, trying to meet that 2,000 to 3,000 milligram, restriction, which isn't based on science, is detrimental. So this is a really good slide to show that in research. So as I mentioned again, the bioavailability of potassium matters and the dietary pattern matters. So it's about the whole picture, how we eat day in and day out. And people that do eat more fruits, more vegetables, the DASH diet approach, or something like a Mediterranean diet or more vegetarian diet approach is a good thing. And you can see that in all of these studies, there was actually no relationship to high potassium. And some of these studies were, over shorter duration. And one by Goraya was over a longer time period, and it was an RCT. So I'll go into more detail for that one. In the highlighted study by Morty, there was one patient who had 2 episodes of hyperkalemia, and that was because they had renal tubular acidosis. So it was an unrelated medical reason for their hyperkalemia. They did switch the bean source, so the soybean source, and found that the potassium corrected itself. So that was an interesting finding, but I don't think we can extrapolate that for everyone. So for people on hemodialysis, does it make a difference? Does dietary potassium affect outcomes? If we let people eat more of the foods that they want, have more dietary variety, is there a relationship for outcomes? And in fact, there was a positive relationship that people who ate more potassium actually did better as well. So the benefits of dietary potassium intake through, the right foods is that you help lower blood pressure, you can reduce cardiac events and cerebral events, you have better bone health, you can reduce kidney stone risk, and really reduce the progression of CKD. In terms of acid-base balance, there's the study that I've shown here by Goraya and al. Is indicative of a 5-year period of using fruits and vegetables versus bicarbonate tablets versus usual care in a 100 or so sample of CKD patients. And what was found was that, in fact, people that were on the fruit and vegetable arm of this randomized control trial did the best in terms of their outcomes. And those outcomes were that they had a smaller drop in GFR, they had better blood pressure control, and they had better cholesterol profiles, which is representative of cardiac health. So this is a really good infographic to show the power of fruits and vegetables. So this is where Atiq will go into some really exciting prescription pattern findings from our PROMISE database around how we manage hyperkalemia with medications. And we know we have some novel potassium binders now on the market, but it's still really interesting to see across BC, how do we use our medication versus, our dietary and allied health management to control potassium. So Atiq will go into that after my presentation, but there's certainly room to use medications to help regulate potassium levels if dietary counseling and other medical factors have been ruled out and acidosis has been controlled. Then we can control those potassium binders. So I look forward to sharing with you Atiq's findings. So if I haven't sort of alluded to this yet, I will in this slide. Potassium is in everything. So this is a really big problem when we start to do our math and put, the 2,000 to 3,000 milligram restriction on things. Even when we do nutrient analysis on recipes, it's scaring people because they'll see, oh, wow, this recipe has 1,000 milligrams of potassium. Well, I can't eat that. That's going to be half my budget. We can't think about food like that anymore because potassium is in everything we eat and we need food and we need a variety of it. We really need to balance out this philosophy with controlling our serum potassium levels. And we know now from what I've shown you that, serum potassium isn't really that much related to what we eat. So yay, this is like exciting, but also probably quite scary for patients listening in because, it's going to take time for us to really be able to swallow this concept literally and figuratively. So there are some things to consider. So patients, if you are listening, people who are dealing with high potassium levels, these are some good things you can practice to help reduce the potassium, because sometimes, doing these things does help. So for example, double boiling potatoes, soaking and cooking, I should add, your legumes, limiting cooking time of soups, because you're not discarding that cooking water. That's where all the potassium is. So soups and stews, if you keep the cooking time lower, it helps. Really shopping for high fiber foods, reading labels for those potassium additives, and trying to limit processed food. And what do we mean by processed foods? Yes, deli meats, we know inherently a lot of them have potassium additives, but even if it's not an additive containing food, if you are concentrating like juicing or making a soup stock, or using products that are a bit more processed, like dairy-based alternatives, even some plant-based burgers, like, just be careful, read the labels, and make sure that there aren't any additives in these processed foods. So cooking potatoes does reduce the potassium content by 70%. We recommend double boiling. So you would just cut the potatoes up. As you can see in the study, the cutting increases the surface area. And then if you do normal cooking, just bring the potatoes to a boil, then discard that water and boil again, you will actually reduce a lot of the potassium. So that's an important consideration if people are having, repeatedly really high potassiums and they love potatoes. So that's something that you could do. With legumes, soaking alone didn't really reduce the potassium content, but if you cook, the normal cooking process did reduce potassium content quite a bit. So what you can do is you can either buy canned beans or legumes, or you can use, again, a cooking method such as normal cooking or pressure cooking, and that does reduce the content of potassium in legumes by 70%, which means you can include legumes all the time in your diet, no problem at all. So again, the benefit of having more plant-based foods is that there's a higher excretion, and I mentioned that the colon adapts in chronic kidney disease to excrete up to 80% of potassium. And so it's really, really important to make sure high fiber intakes are maintained. And, fiber is something you kind of need to bump up gradually over time. So it's really important to work with a dietitian to do the swaps from a lower fiber to a higher fiber recipe or meal. And that way you can gradually increase your fiber intake comfortably and see the benefits on the potassium level, as well as across the board on health. Potassium additives is another area that is really, really important and requires, a lot of self-management, label reading, and educating on what to look for. So potassium chloride is a main potassium additive in a lot of foods. And you can see that across the globe in the study, up to 50, 60, 70% of products have potassium additives. And so it's really important to be aware, as I mentioned, of, processed ingredients. These are things like ice cream, cereal, any type of, fruit leathers or processed fruits and vegetables, veggie chips, whatever, things that say they have vegetables in them but are really processed meats, seafoods, sauces, snacks, breaded products, ready-to-eat foods. Have a look. If they have potassium additives in them, it's really important to try to limit those foods, try to choose an alternative that doesn't have potassium additives. And if it's something simple that you think you can make at home, like a dressing or a sauce, that's always the best thing to do. So again, it's that relationship that, we have with our patients as dietitians, that we navigate this because this doesn't happen overnight. It's very difficult. And, I have full compassion for that, that potassium is pretty well everywhere in most processed foods, but we can navigate that. And certainly people have found, with some tricks and tips, they can navigate this world well. I do think this is also an advocacy piece for healthcare providers, that we really need to lobby for fewer potassium additives in foods just to prolong shelf life. So here are some examples of potassium additives, their names for your reference, and just interesting that salad dressing can have additives as well. So hyperkalemia management conventionally included restricting the absolute amount of potassium. And now hopefully we can walk away and know that, plant-based eating actually reduces cardiovascular disease risk, mitigates the risk of acidosis, improves diabetic control, digestive health, and that diets that are high in fiber are in fact protective long-term against the progression of CKD, and they also help protect heart and diabetic health. So in 2020 and beyond, there's been a rise in the Plato approach. So a plant-dominant, low-protein diet. So we still want to keep the protein to 0.6 to 0.8 grams per kilogram per day. But we want more of the protein to come from plant-based sources. And because plants have fibers in them, we can be a bit more flexible with the amount of total protein that is being taken. And when we look at plant-based eating, we're also considering higher fiber intakes there. So it's a really nice way to go. And they've shown better outcomes, obviously, on CKD progression, delaying, progression to kidney failure and dialysis, cardiovascular health, and overall survival. People have better quality of life because they have more dietary variety. We're not restricting, we're saying open your diet up, try new things. So people are more agreeable to doing maybe low sodium eating now that they don't have to do 10 other different things. And there's absolute safety in this without any consequences on serum potassium or glycemic control, muscle mass loss or frailty. And in fact, what's neat about the plant-based diet is it reduces the pressure at the level of the kidney, and it creates a better environment to prevent acidosis. And so, if the blood vessels are more dilated with the plant-based eating, you have better circulation in the kidney and better protection long-term. And that's the mechanism around that. And along with a low sodium diet, the plant-based eating is a really beneficial adjunct. So I just want to say, when we get a call for hyperkalemia, we start with really asking the questions around hospitalization, blood loss, medication changes, dehydration, diabetes control, and medications that are over the counter, and constipation first. So whether you're a healthcare provider that's a dietitian or not, these are questions that are worthwhile to ask. It helps us a lot when we do get the dietary consults that we don't have to go through all this. We already know the reason that we're getting the referral is because of diabetes control or constipation. So this is a really good way to start because, and I say this with an advocate lens, okay, for patients, because as soon as there's a high potassium level, a lot of patients get told, well, stop eating bananas. And some of the patients, they don't eat bananas in the first place. So it's really important not to go to food first and to really look at the medical management side of hyperkalemia. Then, yes, we can go into the dietary management, look at beverages, look at potassium additives, processed foods, snack foods, refined cereals, animal proteins that are processed. And then we can ask about fruits, vegetables, and plants, and just check it out. Are you, using canned beans, which are lower in potassium? Are you cooking the beans really well? Are you double boiling potatoes? Then we can go into those questions. So now I hope that, the patient experience will shift and patients will feel less overwhelmed, less scared, more excited about joyful eating and trying new foods, bringing in their cultural food traditions more, rather than feeling they're getting mixed messages, told they can't eat anything. So I hope this talk will spark that conversation, and there's certainly more conversations to come around that, because it's really about showing up for the patients and speaking from a united and sort of collegiate and collaborative approach. So other tips, for patient outcomes is it's always really good to refer to a dietitian. We love referrals. A lot of the times people haven't really had a chance to talk to us, go through their diet. We can provide reliable information, individualized recommendations, and start with the processed food first, really explore, dig deep. We have the time to do that. And most importantly, we're here to help all of us, I think, empower patients to come up with their own answers and sort of write their own story of how they want to live their life and run their health. I think that the best way to bring, any recommendations to life is through food and through recipes, and really bringing up joyful eating, making sure that we recognize people's social lives as well and the events that they go to, and just really helping them, manage that. And plating is a really important way of looking at food, enjoying the food so you don't feel restricted, and really using a lot of seasonings and flavors, like you can see here with the recipes. We have so many spices and things to really bump up the blandness of food, because fruits and vegetables, they can taste bland, but there are really good ways of exciting, excitement on the plate. So I'll hand over to Atiq now to talk about pharmacological management of hyperkalemia, and then we can answer questions.
Thanks, Dani. Over to you, Atiq.
Thanks, Dani, for your nice informative presentation, and thanks everyone for the opportunity to present our work. I'm gonna present the prescription pattern of cation exchange resin, that is sodium polystyrene sulfonate and calcium polystyrene sulfonate. These are the two pharmacological medications that are currently funded in BC in treating hyperkalemia. And our objective in this work was to investigate the trend of this SPS and CPS utilization among treating the chronic hyperkalemia in CKD patients registered in PROMISE. We had two specific aims. We wanted to investigate the trend of the prescription utilization, and second, we wanted to estimate the clinical outcome. We defined that by decreased mean potassium concentration. So we used a retrospective cohort approach using PROMISE registry database. The study spanned for 6 years, from June 2015 to July 2021. Our study population was CKD patient registered in PROMISE who were followed in the kidney care clinics. And the definition for chronic hyperkalemia used was they had to have at least 2 potassium values greater than 5 millimole per liter, and it has to be within 90 days. And the index date of these 2 potassium values, we took the first date of the potassium measurement. And once the patient entered into the cohort, we followed them until CRF registration end, or their PROMISE deregistration, or they have a incident kidney failure, like they start dialysis or get a kidney transplant, death, or a study and death. So it's a long follow-up period among our CKD patients. We excluded patients who are less than 18 years. So the study sample had all adult patients. They did not have any kidney failure before their index date, neither dialysis, chronic dialysis, or neither kidney transplant. And they did not receive any SPS or CPS within 90 days before the index date. So all the prescription we will see in our study sample was incident prescription after they were diagnosed with chronic hyperkalemia. So we have already talked about this. We first looked into the total number of patients they were ever treated with pharmacological drugs during the entire treatment period. That means they received at least one prescription of SPS or CPS. After that, we looked into the median time from their diagnosis until they start their treatment with SPS and CPS, and total and the median number of prescription dispensed to patients. And for the clinical outcome analysis, we looked into the 90 days continuous treatment with these medications, and what was the difference in the mean serum potassium concentration before and after the treatment. So the most exciting part of the result of this presentation is the results. So we found 13,435 patients. They met the definition of the chronic hyperkalemia. After excluding excluding criteria, our study sample include 10,495 chronic hyperkalemia patient. The median age was 74 years. 60% of the study sample was male, and the median time of follow-up was 625 days, so close to 2 years. If we look into the table 1, we presented it treated with medication, and they never got a prescription during the entire follow-up period. So what we see, only 27% of the close to 10,500 patient was ever treated the SPS. So 1 in 4, that means that results in 1 in 4 chronic hyperkalemia patient ever treated with pharmacological therapy. So if we look into their disease severity as at baseline, what we see is the moderate hyperkalemia, that is serum potassium concentration greater than or equal to 5.5 millimole per liter. The proportion of patient in treated group was double compared to not treated group. And in terms of all the comorbidities, it appeared to be well balanced, except for diabetes that was higher among treated group. And people who were treated with pharmacological therapy were much longer followed up compared to the non-treated patients. So as we said, only 2,900 patients, close to that 27% of hyperkalemia patient was ever treated. A total of 7,300 prescriptions were dispensed to this population over the entire study period. Most common medication was the SPS, accounted for 88% of the medication dispensed. Median number of prescription dispensed per patient over the study period was 2. And this is interesting. It looks like the patients were not dispensed with pharmacological therapy as soon as they were diagnosed. There was a long latency period of median time of 154 days before they were first handed a SPS or CPS prescription. And there was around median number of tests of potassium measurement during this period was 5. So it appears that our nephrologist had a active monitoring before starting the pharmacological therapy in this patient. Distribution of doses, we had 73,000 prescription, 88% was for SPS, and 15 grams was the most commonly prescribed, so account for almost half of the entire prescriptions, both for SPS and CPS. If we look into the clinical outcome, so 2,100 patient, that is 73% of the ever treated patient, they were treated continuously for at least 90 days. So from the 90th day post-treatment, of this 2,100 patient, 84 patient never had a potassium value recorded. And we have seen the median time for post 90th day treatment for potassium measurement was 23 days, with a wide range of 0 to 637 days. And we have also seen from the index date until they first handed over the prescription, there is a 154 days of wait time. So what we did for the clinical outcome, we restricted our analysis to 649 patients. They met 3 criteria. That means they were at least continuously treated 90 days. They had a potassium measurement recorded within 15 days before their treatment start, and they had another potassium measured within 15 days from their 90th day of continuous treatment. And then we compared this difference and appeared that this is the effect of the medication. So if we look into this diagram and the result, so what we see from the baseline and with this active monitoring period, the serum potassium concentration increased by 0.16 millimole from mild to moderate level of hyperkalemia. Then after a 90 days treatment, it reduced to 4.98 with a decrease of 0.60 millimole per liter. And this range falls into the normal range. Interestingly, if we look into the disease severity, so at baseline, there was no normal because everyone was hyperkalemic, and moderate was only 39%. During this active monitoring period, the proportion of patient at the moderate hyperkalemia, that is with having a more than 5.5 millimole per liter, reached up to 70%. And at the end of 90 days continuous treatment, this substantially reduced to only 18%, and 45% of the patient reached the normal level. Interesting to see is from baseline and before the treatment, pharmacological treatment is start, 10% of the patient appeared to have normal. So that further supports this active monitoring period. So our take-home message is in British Columbia, the chronic kidney disease patient is in PROMISE. 1 in 4 CKD patients with chronic hyperkalemia were received pharmacological therapy, mostly with higher degrees of hyperkalemia, and the most frequent prescription was for SPS. And these medications appear to be moderately effective in reducing the serum potassium concentration. One major limitation of this study is that it's a descriptive study and we had no control group, so we cannot attribute this total decrease in serum potassium to the medication only, because there are other steps, as Dani mentioned, that reduces serum concentration. And we need further research with appropriate control group or to compare the effectiveness with new generation medications such as petiromar or the sodium zirconium. And I'll stop there. Thank you.
Thanks, Dani and Atiq. That's, I think, very provocative and interesting talks. If you could just stop sharing your screen and we can all go back on thing. There are a number of questions. I think it's really great, Dani, to be reminded of the physiology of potassium and maybe remind ourselves about some of the mythology. And I think from a patient-centered perspective, it's really important. I can imagine, as you stated, though, that it's going to be a very big uphill battle to not just for the patients, but for the physicians and the dietitians and the pharmacists and everyone, because we have spent so much energy. And then as Atiq points out, there must be an intrinsic understanding of some of this, because really, despite the fact that we get lots of phone calls and everything else, only 25% of people are on chronic SPS. And as Atiq also pointed out, and many of you will know this, but the data for SPS comes from one study in 1959 or 61 or something like that, of about 30 people. And it's not that effective, actually. And so we are using a non-evidence-based therapy in not that many people to do something that doesn't maybe need doing. So I think it's kind of an interesting pause for us. There are a number of questions, and I'm going to try and amalgamate some of them. I think one of the things is whether or not there are going to be renewed education and handouts for patients and providers, because this is a very big myth to undo. And I think that that's a big piece of work. So maybe I'll...
Absolutely. I think yes, the answer is yes. There are locally, working on some handouts and updating. On a national level, I will say it's been really interesting having conversations with national organizations that still insist on having the milligram tables, because there's a demand from the viewership of a lot of these health websites that the milligrams be indicated. And I think it gives people a lot of comfort to know the milligrams. But I hope now, you'll walk away and take those tables with a very sort of critical lens, okay, that you don't just translate that into that's what's happening in my body. I hope that you walk away sort of understanding that, exactly as Adira mentioned, there's more to potassium, and give your body credit, that it's doing a lot of what it needs to do. And yes, this is a long answer, but the short answer is absolutely. We need to really revise things and come together as an interdisciplinary group of healthcare providers to better educate our patients and bring patients into these groups as well for their input and insights.
Great. There's also some questions about managing potassium by adjusting the dose of binders that are taken at mealtime. And I guess that's like a double-edged thing. If in fact there is a high potassium load in the food, but it's actually not the reason that the serum potassium is high, then I'm not sure that when you take the binder matters, and which binder you take may matter, but I don't know if you have a thought on that.
I don't think, like, working with Judith, I don't think that was, I had asked her that in the past, and I don't think that was going to make a big difference, because I understand there's a lag period for the binder to maximize its effectiveness. And like, it would be really great to be able to do that, right? You're taking it and it's working within this time, kind of like insulin. Like, it would be really cool to know if there was the best time to take it, to time it to your meals. My suggestion is really don't put all your potassium eggs in one basket. Don't try to overeat at one meal, because about that circadian rhythm, right? So it's kind of like, if you have a circadian rhythm where your high points are 1 to 3 p.m., maybe don't make that your highest potassium meal. Like, do something with more.
Very good point. Yeah.
Right. And then make sure your meals are balanced. Like, oftentimes people will.
Maybe blood work in the evening.
Yeah. Which is, that's a whole other, I know, wouldn't that be nice? Like a 9 p.m. blood draw where, your potassium's at its lowest. But patients get worried, right? And providers too, when we see those high numbers. So understand that even the high number that you're seeing could have a lot of implications that aren't. Don't blame yourself for what you ate right away. Okay. So there's lots of reasons why that number is high. That's why, unfortunately, we have to ask for repeats and things like that. And how many times have we done that and the next number has been normal, right? So, yeah.
Yeah, I'm just conscious of the time. I think that, your presentation, I think one of the things that's really great in nephrology is that it's a really changing time, and our understanding of and our revisiting of physiology that hasn't changed, and our understanding of medications that have been used for various reasons is improving and changing. So I think this is incredibly timely. It will be a very large sell to change something that's been ingrained, no pun intended, for so long in so many people. But I think if one thinks about a change management program, and then to the work that Atiq's been doing, I think it's also interesting for us to reflect on the fact that only a quarter of the people who have hyperkalemia are getting treated. So there must be an intrinsic understanding or monitoring that we kind of know that maybe it's not always in that one number that you see. But I hope everybody on the call sort of has pause, think a little bit more about it, think about how we're going to use this information and how we're going to socialize this to patients, providers, and others. Because I think it is a new era. And yes, there are new ways to lower potassium, and we need to figure out in whom and why we're doing that. But no, thank you both for outstanding, thoughtful presentations of both the data that exists and then some novel data from our own province. So again, thanks everyone for participating. You had up over 80 people at the high point. So really terrific. Thank you so much.
Thank you.
Thank you.